We are live.
Yeah. Hello, good evening, everyone. So, I'm Dr. Kapil Goel. Today, we have all gathered here to discuss the latest update on cancer treatment 2025. Today, we are going to discuss a very important topic that is non small cell lung cancer, particularly focusing on EGFR mutated lung cancer. Today, we have an esteemed panel of speakers who will be giving their talks on different topics. And it is my pleasure that all of us have gathered here to discuss the topic in detail. For this, today's agenda is going to be first, I will be taking a talk on advanced EGFR mutated NSCLC and evidence based review of targeted therapies. Second talk will be given by Dr. Nitin SG, who will be talking about reimagining CNS mutation in EGFR mutated advanced lung cancer, how treatments compare. Third talk will be given by Dr. Anshul Gupta, overview of lung cancer. And final talk will be given by Dr. Aman Chaudhary, who will talk about how to proceed lung biopsy, principles of molecular and biomarker analysis. With this background, I welcome all the delegates for this symposium and all the speakers, and we are hopeful that today we are going to have a fruitful discussion. So, with that, I would like to start my first talk. So, program director, can you please share my slides? So today I'm going to talk about advanced EGFR mutated NSCLC and evidence-based review of targeted therapy. Next slide, please. If we look at the lung cancer epidemiology globally, in 2020, it accounted for uh, second most common cancer diagnosed in males, and it is the third most common cancer in females. It is also number one cause of cancer-related mortality in males and number two in females. However, if we talk about India, according to 2020 data, lung cancer is fourth leading cause of cancer-related deaths in India, and it is fourth in terms of overall incidence. If we look at the percentage of different cancer, lung cancer accounts for 5.5% of total cases, with total of 72,510 new cases every year. NSCLC is the most common type of lung cancer, as we know that the other type of lung cancer is small cell lung cancer. Next slide, please. If you look at the relative survival rate, then obviously it varies by the age and diagnosis. Compared to stage 1, 2, 3, and 4, if we see, so very few patients are diagnosed at stage 1, only 1.2% patient. However, they have excellent prognosis with almost close to 85 to 90% 5-year survival rate. However, if we come to stage 2, only 3.8% patients are diagnosed in this stage, and each patient survival decreases sharply to around 60% in 5 years. Many patients diagnosed in stage 3, that is almost 30% of the total patient. Here, the survival drops significantly to only 30% for 5-year survival. However, majority of the patients get diagnosed in stage 4, that is two-thirds of the total patients, and 5-year overall survival is only 10%. It is extremely dismal. So that is why it is important to know about the recent advances in terms of metastatic or stage 4 NSCLC. Next slide, please. Now, initially, we were doing only the histopathological examination of biopsy, where we used to divide the small cell lung cancer or non-small cell lung cancer, only two types. Later on, as the IHC marker came in picture, we started categorizing them into adenocarcinoma and squamous cell carcinoma. The non-small cell cancer got in various varieties like adenocarcinoma, squamous cell carcinoma, or large cell carcinoma. Furthermore, we have started classifying these agents according to the biomarker, and it has been seen that more than 50% of stage 4 NSCLC have some kind of biomarker. There could be predictive biomarker as well as prognostic biomarker. Predictive biomarkers are indicative of therapeutic efficacy because there is an interaction between the biomarker and therapy on patient outcome. However, if you talk about prognostic biomarkers, they are indicative of patient survival independent of treatment received because the biomarker is an indicator of the innate tumor aggressiveness. Testing for several genetic mutation and for PD-L1 status is recommended for patients with advanced NSCLC to determine whether they can receive treatment with targeted agents. If we look about the spectrum of mutations, more 36% patients do not have any kind of mutation. In those who have, Approximately 25% have KRAS mutation, which is the most common mutation. It has been seen that the KRAS mutation lead to increased tumor cell proliferation, and these are particularly aggressive type of tumor. Next most common is EGFR mutation, which is present in 17% of the patient, and this mutation drives tumor growth and predict response to EGFR TKI. 8% tumors are ALK mutated, which is ALK rearrangement, enhanced tumor growth. These tumors are responsive to ALK inhibitors. Approximately 6% patients are NRAS mutated. Rest rare mutations are HER2, BRAF, PIK3CA, MET amplification, and so on. Next slide, please. Now we come to the testing methodology for target mutation in adenocarcinoma. So mainly we have 4 different type of testing methodology: the FISH, IHC, and PCR based. For EGFR testing, we can only use PCR based test, and FISH and IHC are not used for this. Also, next generation sequencing used. For ALK, FISH is preferred, although IHC is also equally acceptable. ROS1, same. FISH is the treatment methodology of choice, but IHC is acceptable. For PDL1, only IHC is done. Next slide, please. Now we talk about the EGFR driver mutation in lung cancer. So this is the most frequent EGFR TKI sensitizing mutation that occurs in exon 19 and 21. If you look at the TKI domain from exon 18 to 21, so there are 4 different exons: exon 18, 19, 20, and exon 21. So exon 18, we have different mutation like G719C, G719S, and G719N, or exon 19 mutation. Exon 20 insertion mutations are seen sometime. With exon 21, the most common mutation is L858R mutation. All of these mutations are associated with some kind of drug sensitivity. Next slide, please. So based on limited number of studies, the prevalence of EGFR mutation appears broadly similar across disease stages. If according to an overall estimated prevalence, the Asians have 30 to 40% rate of EGFR mutation, while in Caucasian population, it is only 10 to 20%. If we look at the prevalence estimate for each stage across the Asia, US, and Europe, you can see that Asians have the highest prevalence of EGFR mutation across the stages. From stage 1, 2, 3, and 4, the prevalence remains almost same, that is almost 30 to 40%. While in US population, it is 19 to 20%. For the European population, it is somewhat 10%. So if EGFR TKIs were available in the resectable setting, a similar portion of patient may be able to benefit compared to the advanced setting. That was the hypothesis given. Next slide, please. Now we look at where NCCN guideline stand regarding EGFR testing. So NCCN recommends EGFR testing in early stage NSC as well, and responsiveness to oral EGFR tyrosine kinase inhibitor. Most recent data indicate that tumors that do not harbor a sensitizing EGFR mutation should not be treated in EGFR TKI in any line of therapy. Next slide, please. Now, how does it work? The EGFR activating mutation results in constant signaling by the EGFR. On the left panel, you can see how the EGFR wild type, that is the normal protein, works. So this pathway is on only when EGF is bound to the receptor, and hence it is without the receptor binding, it does not work, and downstream regulation pathways are inactivated. However, in the mutated EGFR mutated pathways on even when the EGFR is not bound. So this receptor is constantly activated, and through the downstream signaling, it gives signal for cell proliferation and further cell survival. Next slide, please. If you look at the current treatment option for advanced lung cancer, for first line molecular markers are tested. If we have ROS1 fusion, then first line treatment is through Crizotinib, Crizotinib. If ALK mutation is present, then Alectinib or Ceritinib. If EGFR mutation is present, then we prefer Osimertinib. However, in the squamous cell carcinoma, if PDL1 is more than 50% TPS, then we recommend pembrolizumab monotherapy. If PDL1 49% TPS, 1 to 49%, we combine immunotherapy with chemotherapy. PDL1 however, in the squamous cell carcinoma, pembrolizumab is used if the PDL1 is more than 50%, PDL1 1 to 49% chemo alone, and PDL1 less than 1% chemotherapy alone is used. In the second line, we can use various immunotherapy combination if they have not been used in the first line. Next slide, please. Now we know that osimertinib, which is a third generation irreversible CNS active EGFR TK selective for both EGFR mutated and EGFR T790M resistance mutation. If you look at the osimertinib, so it acts on EGFR T790M mutation as well as EGFR mutated L858R exon 19 deletion. On wild type, it does not act. So inhibition of EGFR mutated, inhibition of T790M mutation, lower activity against wild type EGFR. It crosses the intact blood-brain barrier as seen in the preclinical model, which is responsible for its activity in brain metastasis. Next slide, please. Now we'll discuss the trial, that is the FLORA trial. It is a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as first-line treatment in patients with locally advanced or metastatic EGFR mutated NSCLC. Next slide, please. So it was a phase 3 double-blind study which was conducted across 132 sites in 29 different countries, in which patients with locally advanced or metastatic NSCLC were taken. Key inclusion criteria were age has to be more than 18 years, WHO performance status 0 or 1 were allowed, exon 19 deletion or L858R mutation were taken, who have not received any prior systemic anti-cancer treatment or EGFR TKI therapy. Stable CNS metastasis were allowed. The stratification factor were exon 19 deletion versus L858R mutation, and according to the race, that is Asian versus non-Asian. So these patients were randomized in 1:1 ratio into experimental arm, that is osimertinib 80 mg per oral every day, that was given to 279 patients. The control arm had EGFR TKI standard of care at that time, that is geftinib or erlotinib. That was given in 277 patients. So these patients were followed up according to the RACES 1.1 assessment criteria every 6 weeks until objective progressive disease happened. Thing to note is that the crossover was allowed in the control arm. Patient with confirmed PD by BICR on SOC and T790M mutation may begin post-progression open label osimertinib. The primary endpoint was PFS based on investigator assessment according to RACES 1.1. It was 90% powered to detect a hazard ratio of 0.71 at a two-sided alpha level of 5%. Secondary endpoints were objective response rate, duration of response, disease control rate, depth of response, overall survival, patient-reported outcomes, and safety. Next slide, please. In the FLORA trial, baseline characteristics are balanced across treatment arm. If you look at the gender-wise, 64% patients were female and 36% patients were male. If you look at the median age, it was 64 in both the arms. If you look at the race, the maximum number of patients were Asian. Smoking status, most of the patients were never smoker. CNS metastasis were there in approximately 20% of the patient. Performance status was 1 in most of the patient. Overall disease classification was stage 4 in most of the patient. Histology of adenocarcinoma in almost all of the patient, and EGFR mutated were more common was exon 19 deletion, that was in 2/3 of the patient, and 1/3 patient in the either arm had L858R mutation. Next slide, please. If you look at the efficacy, that is primary endpoint PFS by investigator assessment, 342 out of 556 PFS event happened at the disease data cutoff date with 62% maturity. If you look at Kaplan-Meier curve, here the osimertinib curve seems to separate very nicely from standard of care, and separation started early on in the follow-up. Osimertinib arm had fewer events, that is 136. Compared to the SOC, that is 206 events. Median PFS of 18.9 months in the osimertinib arm, which were much higher than 10.2 months in the standard of care. Hazard ratio was 0.46. Osimertinib reduces the risk of progression or death by 54% compared to standard EGFR TKIs. Next slide, please. If you look at PFS across subgroup, the osimertinib efficacy was maintained across all subgroups, whether it was according to the gender, that is male or female, age, race, smoking history, CNS metastasis, WHO performance status, EGFR mutation type, EGFR mutation by ctDNA level, or centrally confirmed EGFR mutation. By all of the criteria, the osimertinib group was better compared to the standard of care arm. Next slide, please. If you look at the objective response rates, 80% of the patient had objective response compared to 76% in the control arm. Stable disease for more than 6 weeks was seen in both the arms, same, and PD was more common with the standard of care. Median duration of response, if you see, it was much higher, that is 17.2 months with the osimertinib arm, compared to only 8.5 months with the standard of care. Duration of response was twice as long in patient treated with osimertinib compared to standard EGFR TKI. Next slide, please. If you look at FLORA OS final analysis, the osimertinib overall survival was 38.6 months compared to comparator arm that was 31.8 months only. Hazard ratio was 0.79. The final analysis of OS demonstrated a clinically meaningful and statistically significant improvement with osimertinib versus EGFR TKIs. Next slide, please. If you look at the FLORA adverse event summary, median exposure with the osimertinib was 20.7 months compared to EGFR TKI comparator that were only 11.5 months. If you look at the side effects, the most common side effect were diarrhea and rashes and acne. However, with the osimertinib arm, the grade 3 and grade 4 incidence was much less. Other side effects were dry skin, paronychia, stomatitis, anorexia, cough, and nausea. So we can see that the osimertinib arm, the side effects were much less, especially grade 3 or 4 side effects were much less. It was very well tolerated. Next slide, please. If you look at overview of adverse event safety analysis set, any adverse event was seen in 97.8% with the osimertinib arm, which was same in the standard of care arm. If you look at CTCAE grade 3 or more, it was there in 33.7% patient in the osimertinib arm, which was much higher, that is almost 45% in the standard of care arm. Leading to death, 6 patients died in the osimertinib arm, while 10 patients died in standard of care arm. If you look at possibly causally related, any adverse event, 90.7% in the osimertinib arm, 92% in the standard of care arm. If you look at grade 3 or more, that was also much better with osimertinib, that is only 17.6% compared to 28.2% with the standard of care arm. Next slide. To summarize, osimertinib resulted in highly statistically significant and clinically meaningful improvement in PFS over standard of care with a hazard ratio of 0.46, 54% reduction in the risk of progression or death relative to standard of care with early separation of Kaplan-Meier curves. Consistent benefit in all predefined subgroups, including patient with and without CNS metastasis at study entry. Doubling of duration of response with osimertinib, median 17.2 months versus 8.5 months. A significant and clinically meaningful improvement in CNS PFS over SOC with a hazard ratio of 0.48. Fewer CNS progression events and fewer new CNS lesions were seen. Final analysis of OS results showed promising survival trend following osimertinib versus standard of care. Hazard ratio of 0.799. Preservation of PFS benefit throughout next disease progression and subsequent lines of treatment. It adds confidence in promising early overall survival data seen at interim analysis. Comparable safety profile of osimertinib to standard of care. Overall lower grades of grade 3 or more adverse event and lower discontinuation rate with osimertinib. So keeping all these things in mind, osimertinib is a new standard of care for first-line therapy in patients with EGFR mutated advanced NSCLC. Next slide, please. If we look at the CNS efficacy for osimertinib, next slide. CNS metastasis occur at high rates among those harboring EGFR mutation compared with wild-type EGFR. If you look at the brain metastasis in patient with EGFR mutated, it was present in 19 to 24% of the patient at initial diagnosis, while in wild-type, it was present much less patient, that is 11 to 13%. And during final follow-up, almost double the number of patients develop brain metastasis in the EGFR mutated subgroup, that is 44% compared to 22% in EGFR wild-type. Leptomeningeal metastases were also significantly more common in EGFR mutated patient, 9.4% compared to 1.7%. Next slide. However, the good news is that in osimertinib, in the CNS activity is there, and PFS in patient with and without CNS metastasis at baseline in both these subset, the osimertinib works. And median PFS, if you look at in the patient with CNS metastasis, were 15.2 months compared to 9.6 months in the standard of care arm. While in patient without CNS metastasis for 19.1 months compared to 10.9 months, Hazard ratio of 0.46 in both the arms. So osimertinib benefit was consistent in patient with and without CNS metastasis. Fewer CNS progression events were observed with osimertinib compared to standard EGFR TKIs. Next slide. CNS activity. If we look at the CNS PFS and CNS full analysis set, the median CNS PFS was not reached in the osimertinib arm. It was 13.9 months in standard of care arm. Hazard ratio was 0.48. Median follow-up was 12.4 months in the osimertinib arm compared to 7 months in the standard of care arm. If you look at the Kaplan-Meier curve here also, the Kaplan-Meier curve shows good activity of osimertinib compared to standard of care. Next slide, please. Now we look at data of osimertinib versus dacomitinib. Next slide. So for the efficacy of dacomitinib, we have Archer 1050 trial, which compared dacomitinib with the geftinib. And then we have Flora trial, where osimertinib was compared with EGFR TKI separator. If we compare both trials in Archer 1050, the separation of curve started after a latency of 6 months. While in the Flora trial, the immediate separation of curves was seen. Median PFS of 14.7 months in the dacomitinib arm compared to 18.9 months in the median PFS arm. The osimertinib arm. The hazard ratio was 0.46 in the Flora trial, which was better than hazard ratio 0.59 in the dacomitinib arm. Next slide. Also, the Archer 1050 OS not significantly statistically significant, since the formal comparison of ORR was not statistically significant based on studies hierarchical testing rules. If we look at the overall survival, so it was not better. Next slide. But if you look at the Flora, first time in EGFR TKI has translated PFS to a significant OS benefit. Median OS was 38.6 months compared to 31.2 months, and the hazard ratio was 0.79. Next slide. Early and sustained survival benefit shown by clear separation of curves within 3 months, and it was maintained throughout the follow-up period. Next slide. So Canadian consensus guidelines say that a new systemic treatment algorithm for advanced EGFR mutated in SCLC was given. And with Archer 1050, p-value could not be given to OS because it has a hierarchical stratified design, and given that it did not meet significance in ORR, a p-value could not be given to overall survival. Next slide. Now we have a look at data on osimertinib versus afatinib. Next slide. So here we have to talk about Lux Lung 7 trial, which is comparison of afatinib with geftinib. Here the median PFS was 11 months with the afatinib arm compared to 10.9 months with the geftinib arm. Osimertinib has a median PFS of 18.9 months, which is almost better, double than compared that of afatinib. And there was insufficient event to determine OS of afatinib at the time of analysis. Next slide. There is another phase 2B open label afatinib, that is Lux Lung 7 trial, where afatinib was compared with geftinib, and co-primary endpoint, that is OS, overall survival advantage was not seen, with both the arms showing 27.9 months versus 24.5 months of survival. Next slide. Next slide. If you look at the pre-specified subgroup of interest, exon 19 deletion and 8, both of them showed similar OS. Median OS with afatinib versus geftinib with patient with exon 19 deletion, and here it is the L858R mutation. The curves are overlapping here, and it did not show any major significant OS benefit. Next slide. If you look at the osimertinib safety profile comparison with other TKI, in the Flora trial, the grade 3 or 4 were less than 1% or 2%. While the afatinib and dacomitinib, the side effects were much higher. Maximum side effects were with the dacomitinib arm. Maximum side effect was seen with the dacomitinib. Next slide. So FLORES study was also a sequencing study. So osimertinib was compared with the comparator arm, and which was the sequencing arm, as the first generation TKI was used first because crossover was allowed. So many patients received third generation TKI, that is osimertinib, and it was seen as significant, that is 47% of the patient. And we have seen that first line osimertinib had better results compared to sequencing strategy. Hence, the dilemma of sequencing is also resolved by FLORA study. Next slide. So second line treatment, are all patients eligible for that? So it has been seen that out of 10 patients who are EGFR mutated NSCLC on first generation TKIs, only 73 to 77% of EGFR mutated patients receive any second line therapy. 30% of the patients do not have the opportunity to receive any second line therapy. Also, it is not possible to predict that what patient will develop T790M resistance. So it is better that all patients get benefit of osimertinib in the first line itself. Next slide. So it is important that we start the drug with greater benefit compared to other TK in the first line itself. Next slide. So use of osimertinib at second line therapy in FLORA was consistent with expected rate in clinical practice. If you look at the comparator arm, for 65% patient received second line therapy, and 30% of the patient comparator arm could not receive a second line therapy, which was consistent with attrition rate seen in real world studies and the clinical trial. However, second line therapy division, if you look at, 47% of the patient in the comparator arm who did receive second line therapy, they receive osimertinib, consistent with the expected rate of T790M mutation. Other patients receive cytotoxic chemotherapy. Next slide. Real world evidence have shown that in clinical practice, approximately 1/3 of patients or fewer receive second line osimertinib. Next slide. So if you look at the NCCN guideline, treatment options for patients with sensitizing EGFR mutation positive metastatic NSCLC in first line, osimertinib is the preferred drug, and that is in the category 1 indication is there. Next slide. To conclude, for the first time in the evolution of EGFR TKIs, osimertinib translated PFS to a significant OS benefit. Osimertinib had a median PFS of 18.9 months and median OS of 38.6 months, which is significantly higher than the first and second generation EGFR TKIs. Osimertinib has shown efficacy in patients with CNS metastasis. Fewer CNS progression events were observed with osimertinib when compared to a standard of care EGFR TKIs. Fewer and less severe adverse event gives osimertinib a better safety profile than the other EGFR TKIs. So osimertinib is the new standard of care for first-line therapy in patients with EGFR mutated advanced NSCLC. Next slide. With that, we reach the end of my presentation. So if there are any questions, I'll be happy to answer them. Since there are no questions from the audience, so I would like to invite my second speaker, Dr. Nitin SG. Dr. Nitin SG is consultant medical oncology in CK Birla Hospital, Punjabi Bagh. The topic that has been given to Dr. Nitin SG is reimagining CNS mutation in EGFR mutated advanced lung cancer, how various treatments compare. Over to you, Dr. Nitin.
Hi, hello. Hi, Dr. Kapil.
Hello.
Hi, everyone. Thanks for the invitation and thanks for providing me this opportunity to give this talk. Uh, just a minute, let me share my slide. Are the slides visible? Hello?
Yes, they are visible.
Okay. So good evening, everyone. So the topic I'm discussing would be reimagining the CNS mutations in EGFR mutated advanced lung cancer. How treatments compare. So we all know that the treatment of lung cancer have rapidly changed over the last decade, with treatment extent changing from blanket chemotherapy to targeted therapy and more major role of precision oncology in treatment of non-small cell lung carcinoma, especially in the metastatic setting. And Dr. Kapil have clearly described the role of biomarker mutation and the significance of the same in treatment of lung cancer. So I would be briefly discussing just the significance of EGFR, new EGFR mutations and the role of EGFR TKIs in treatment of CNS metastatic non-small cell lung carcinoma having EGFR mutation. So we all know that non-small cell lung carcinoma constitute around 85% of all lung cancers, and 15% are small cell lung carcinomas. Of the 85% of lung cancers, the EGFR mutated one constitute around 17%. And other mutations like ROS might be around 1%, ALK 3%, MET around 4%. And in Indian population or in the Asian population, the incidence of EGFR mutation is much higher than that of the Western population. So this is the this is a graph showing the distribution of EGFR mutated lung cancers across the world. As we can see, in Asian populations ranging from around 36 to 40%, while in European populations around 12 to 15%. So there is market geographic variation EGFR mutation prevalence ranging from 15% in Europe to 62% in Asia. So patients with lung cancer have got the highest rate of identified brain metastasis, and such incidents are more pronounced in EGFR mutated lung cancers. So over the years, it has been noticed that among the lung cancers, those having EGFR mutation are associated with an increased incidence of brain metastasis. So many of the studies that have quoted have shown that around 44% of patients with EGFR mutated tumors had got brain metastasis as compared to only 22% in those which were the EGFR was wild type. Leptomeningeal metastasis has got the worst prognosis, and if not treated, they have got a survival of only 4 to 6 weeks. Leptomeningeal metastasis may be more frequent in patients with EGFR mutated non-small cell lung carcinoma as compared to wild type EGFR non-mutated lung cancers. So, if we could specifically consider leptomeningeal metastasis, the EGFR mutated lung cancers constitute around 10% of this metastasis. So, approximately 10 to 20% of lung patients, NSCLC patients have brain metastasis at the time of diagnosis, and approximately 40% will develop brain metastasis during the course of the disease. So this is a quality of life index EQ5D score, which actually is a health outcome score in which mainly 5 dimensions are being included. That is mobility, self-care, usual activities, pain, discomfort, or anxiety, depression. As we can see from the cystogram, those patients who have got the brain metastasis has got the worst EQ5D score. And even when the patients might be having multiple metastatic site or even at a single large metastasis, those having brain metastasis has got the worst performance with worst affecting their quality of life very badly. So decline in quality of life is markedly seen in these patients who are having even single brain metastasis. Patient with a single brain metastasis experiencing the greatest decline in quality of life compared to other sites of metastasis. Now, brain mets in EGFR mutated advanced non-small cell lung carcinoma and the role of TKIs. So what we already know, the brain is main sanctuary site for invading metastatic tumor cells as it is protected by the blood-brain barrier. Up to 40% of patients with non-small cell lung cancer with EGFR mutation will develop brain metastasis during the course of their treatment. And EGFR TKS are also substrate for human blood-brain barrier efflux transporters to varying degrees, and this influences the distribution of compound in the brain at equilibrium. Hence, it is imperative that EGFR TKI must have a good brain exposure if they are to achieve intracranial efficacy. So this was a preclinical study which was done on a monkey brain, and it was noticed that osimertinib has got a differential penetration through the blood-brain barrier in monkey brains in preclinical studies. These are various drugs that has been used, and all of these were carbon-11 tagged. And after giving the medication, again imaging was done, gamma camera imaging was done to see the bioluminescence, and it was found that in osimertinib cases, the leptomeningeal distribution is relatively less, but when the cerebrum, the distribution is quite good. Whereas other drugs, we can see that they are mainly not, they don't have a uniform distribution throughout the brain or the cerebral component of the cerebral part of the intracranial component. So osimertinib demonstrates highest mouse brain concentration than other TKI. So there was a comparison between osimertinib and the first generation TKIs like geftinib, rosiletinib, and afatinib. And you can see that at each doses, the brain to plasma concentration ratio is maximum with osimertinib. And the best results are seen when the osimertinib is given at a dose of 25 milligram per kilogram. So brain plasma concentration ratio was ranging in the range, it was in the range of 3.41, which is almost more than 3 times, almost 6 times as that of afatinib. And these studies on animals show that osimertinib has the highest brain penetrance of the EGFR TKIs studied. So this is another graph which shows the bioluminescent uptake, what is your radioactivity that is seen after giving various doses of EGFR TK. And we can see that the graph with blue color, the curve has got the best radioactivity response, and that is seen at a radioactivity level of around 1.5, and even at a very low, and it was lasting for a longer duration of time than other drugs that has been used in the same setting. These drugs actually include dacomatinib, geftinib, which are EGFR TK, erlotinib, lazertinib. These are EGFR TKs which we regularly use for treatment of lung cancer. But osimertinib actually stood apart from all these TKIs with respect to brain penetration. Osimertinib also causes tumor regression in EGFR mutated brain metastasis, and this was studied in a mouse xenograft model PC9. So initially a mouse brain model was made, and in which EGFR mutated lung cancer was confirmed. The confirmation of tumor was done by H&E stain, and then they gave carbon 11 tagged osimertinib, cobalt 1686, and other control medications. As we can see that the bioluminescence will be less if the tumor has got regressed, and we can see that the lowest curve in the curve that is representing osimertinib 25 milligram per kilogram QD. That is the one which has got the lowest, which is at the lower level, and that shows that the bioluminescence is least after giving treatment with osimertinib. That means which was corresponding to tumor regression within the brain. Osimertinib was homogeneously distributed in all regions of brain in healthy volunteers. So this was another study where again carbon-11 tagged osimertinib was given to multiple subjects, and it was seen that in subject 1, 2, 3, and all these subjects, all the images, we can see that it is uniformly distributed within all these healthy volunteers, showing that they can cross blood-brain barrier and thus can uniformly get distributed within the brain. Osimertinib achieves brain exposure in patients with EGFR mutated advanced non-small cell lung carcinoma with brain metastasis. So earlier what we saw was the distribution within the healthy individuals, and these are actually patients who had brain metastasis. As we can see in patient 1, in PET 1, there were these black curves actually represents the metastasis. And we can see that with first initial lesion had got a large size, and after around 6 hours post osimertinib 80 mg, the size was almost same, but there was multiple distribution of the drug throughout the brain, which is represented by reddish shadows. And then by day 2022, we can see that there is regression of the brain lesions, which is represented by small round, small red colored circles. And that shows that the initial lesions, which was much larger and represented by the black color, has now reduced in size after introduction of osimertinib. In patient 2, also we can see similar response with introduction of osimertinib 80 milligram. So osimertinib it is an irreversible inhibitor of EGFR TKI. It binds irreversibly and clinically relevant mutant EGFR kinase various mutations like L88, L858R, exon 19 deletion, T790M mutation, which is a resistance mutation for most of the EGFR TKIs. In those cases also, osimertinib acts well. They bind to these kinase forms to selectively inhibit mutant EGFR kinase activity. It was shown to have a prolonged PFS and OS relative to first generation EGFR TKIs, It exhibited anti-tumor effects in patients with non-small cell lung carcinoma harboring various EGFR mutation, common as well as uncommon. High blood-brain barrier penetrance and brain exposure relative to other EGFR TKI is active against CNS metastasis and inhibited growth of it also inhibited the growth of osimertinib also inhibited the growth of CNS metastasis in patient with EGFR mutation positive non-small cell lung carcinoma. How does the efficacy of osimertinib vary as compared to first generation TKI in treatment of EGFR mutated lung cancers? There have been multiple studies, but the FLORA trial, which was a recent trial, and there was an updated data also from this trial. Here, EGFR mutated metastatic non-small cell lung carcinoma who were previously untreated were given first line osimertinib, and they have been compared with first generation TKI for response. Now, patients with EGFR mutation positive advanced non-small cell lung carcinoma, around 994 patients were screened, and ultimately around 556 patients were randomized, and it was a double-blind trial. The primary endpoint was after PFS 342 PFS events, and the secondary after 321 deaths. And osimertinib 80 milligram per day was given to patient. It was compared with first generation TKI, erlotinib, and geftinib. And PFS and OS were the major outcomes that was measured. So in FLORA trial, around 95% of patients had metastatic disease, of which 21% of patients had got CNS metastasis. So efficacy of osimertinib in the first-line treatment of EGFR mutation positive advanced non-small cell lung carcinoma in FLORA. I'm not going to details of this because Dr. Kapil has already discussed the same. So PFS was much better in patients who had received osimertinib, and they also had a longer OS as compared to first-generation EGFR TKI. And at 24 months, 74% of patients receiving osimertinib were alive, while 59% of patients with comparator EGFR TKI were alive. And at 36 months, it was 54% versus 44%. Now we'll be concentrating main on the CNS metastasis, those patients who had CNS metastasis, and what was the CNS results in FLORA trial. So this is the Kaplan-Meier curve. The first one actually shows this results in patients with non or treated CNS metastasis. There was 116 patients. As we can see that in patients who had non-CNS metastasis, the curves are markedly separated, with osimertinib having a median PFS of 15.2 months versus standard of care of 9.6 months and hazard ratio of 0.47, which was statistically significant. The second curve shows mainly the PFS results in patients who did not have a non or treated CNS metastasis. In such cases, of course, the median PFS was much better, but it was definitely much better than the standard of care, 19 versus 10.9 months with a hazard ratio of 0.46. So CNS progression even was occurred in 17 patients, that is 6% of patients who received osimertinib, while 15% of patients who received standard of care or first line EGFR TKI, 15% of patients had CNS progression during the course of treatment, while those receiving osimertinib, there were only 6% of patients who had CNS progression. So in FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status at study entry versus EGFR TKI comparator. So this is another comparison between osimertinib and EGFR TKI in first-line treatment of EGFR mutated lung cancer. As we can see that this is a CNS full analysis, of which 61 patients have received osimertinib, while 67 patients received EGFR TKI. The CNS PFS was not reached in patients who received osimertinib, while it was 13.9 months in patients receiving first-generation TKI, with a hazard ratio of 0.48. And CNS objective response rate was much higher for osimertinib, 66% disease control rate with 43 versus 43% in first generation TKI, and with the odds ratio of 2.5. So osimertinib had significantly longer OS as compared to EGFR TKI in those patients who had CNS metastasis as well as those who didn't have CNS metastasis. But those with CNS metastasis did very well, and there was lesser CNS progression during the treatment course. Intracranial PFS, again, the Kaplan-Meier curves shows that osimertinib has got a much better response with respect to CNS PFS, where as we discussed earlier, the CNS PFS was not reached in osimertinib versus it was 13.9 months in first generation EGFR TKI with a hazard ratio of 0.48. So another comparison, CNS progression other than death. So CNS progression by BSCR as an analysis was found that around 20% of patients had got CNS progression in osimertinib arm, while it was 39% in comparator EGFR TKI arm. Again, it was statistically significant towards CNS, towards osimertinib. No only treats, but also it. So this shows that osimertinib not only causes tumor regression and improves CNS progression-free survival, it also prevent further progression or appearance of new lesions. So it's not just only to treat CNS metastasis, while those patients who did not have any baseline brain metastasis, in those cases, it even prevents development of online CNS metastasis during course of treatment. This is another reason for CNS progression by investigator assessment. Here, number of patients with CNS progression. Progression CNS only was seen only in 6 patients in osimertinib, while it was 16 patients in EGFR TKI arm. In those patients who already who had CNS metastasis, in those patients, only CNS progression was seen only in 3% versus 10%, while those patients who did not have any brain metastasis, in those cases, only CNS progression was seen in 4% patient in the osimertinib arm, while 12% in EGFR TKI arm. So in the phase analysis, which included patient with or without CNS metastasis at trial entry, investigator assessed CNS progression events were observed in 6% of osimertinib arm patients in the osimertinib arm, while 16% in comparator EGFR TKI arm. So again, further results, we can see that patients who have remained in the study or in treatment at 12 months, around 70% of patients were still continuing on treatment with osimertinib. And at the end of 36 months, it was around 28% of patients who were continuing treatment on osimertinib, while there was only 9% of patients who were on first generation EGFR TKI. So first line osimertinib may delay the need for subsequent therapies. So as we discussed, 28 versus 9% were continuing treatment at 36 months. Some real world evidence of osimertinib with CNS metastasis. So this was this was 2 case reports that has been discussed and that has been published, where rapid intracranial response to osimertinib without radiotherapy in non-small cell lung carcinoma patient harboring EGFR T790M mutation was seen. So in case 1, a 67-year-old woman without a history of smoking who had Behçet's disease underwent right middle lobe resection for lung cancer 9 years ago, and they later presented with multiple lung metastasis, both lungs, and which is suggestive of recurrence. Patient had EGFR L5858R mutation. The patient was started on Geftinib, first line chemotherapy for 2 years. And sorry, Geftinib was given in the first setting, and patient continued well for around 2 years and 11 months. And after 3 lines of, and after that, after having progression, patient was started on chemotherapy as well. And after 3 lines of therapy, patient further had progression. Erlotinib was given in the 5th line of chemotherapy. There was not much response, and in 6th line chemotherapy also there was not much response. And then further investigation was done. Repeat biopsy was done. See, they identified T790M mutation in exon 20. As 7th line option, they actually started the patient on osimertinib 80 milligram per day for the next brain nodules, and the patient was having an ECOG PS3 at that time. On day 5 after administration of osimertinib was started, a chest X-ray showed that there was shrinkage of the right pulmonary nodule. And CT images on day 13 reveal complete remission of brain metastasis except for 1 lesion in left frontal lobe. And the patient who had PCOG PS at 3 at the starting of osimertinib later had improvement in their performance status and became better and was performance status 2 by end of 3 weeks. In addition, other blood reports, other bone lesions, bone related lab reports, everything became normal after starting osimertinib. So a patient underwent right middle lobe resection. So we described the same case. I'm going to the next one. So this is the X-ray. This is the imaging pre-treatment. She had multiple brain lesions, and at day 13 there was only single lesion in the right frontal lobe, and lung lesions also shown shrinkage. Case 2, another 76-year-old woman with a history of smoking, again underwent surgery for non-small cell lung carcinoma 10 years ago, and had EGFR exon 19 deletion. So, patient had developed multiple multiple bone metastasis in the recurrent setting, and was started on Geftinib. She did well for around 4.5 years, and then after on progression, she was started on Afatinib for around 10 months. She was doing fine. And then she was also sandwiched chemotherapy with carboplatin, pemetrexed, bevacizumab, and none of these did well for the patient. So after multiple line, patient was again evaluated and an additional mutation T790M was identified, and patient was started on osimertinib in fifth line. And at that time, ECOG PS was 2. On day 10 itself, it shown that there was a remission of single brain metastasis, revealed that remission of single brain metastasis in the right parietal lobe, which was asymptomatic. And on day 14, there was pleural effusion, all the pulmonary nodules, everything started decreasing and showing symptomatic improvement. And patient performance status also improved from ECOG P2, ECOG PS2 to ECOG PS1. So again, this is the image for the patient. Pre-treatment, there was a lesion. It was asymptomatic. Even though patient had a brain metastasis, it was asymptomatic. At day 10, it shown shrinkage and complete remission at day 10 of osimertinib treatment. And lung lesions and pleural effusion, as you can see from the image, there was marked reduction in the pleural effusion, and left-sided pleural effusion completely resolved at day 31. Now, complete remission of multiple brain mets in a patient with EGFR mutated non-small cell lung carcinoma treated with first-line osimertinib without radiotherapy. So, another case where 4-year-old lady, non-smoker, elevated blood carcinoembryonic antigen level. CT scan revealed 40 millimeter shed on the brain in the upper lobe of left lung with multiple nodules in the entire lung. So she was diagnosed with stage 4 lung cancer, and luckily she was having an EGFR exon 19 deletion mutation. I would say those patients have lung carcinoma and definitely have an exon EGFR mutation, they are lucky. They are unfortunate to get this disease, but with stage 4 disease having an EGFR mutation, definitely being fortunate. More than 20 multiple asymptomatic brain mets with a major, there were multiple brain mets were also there. Patient was started osimertinib. There always been confusion whether to patient to be given whole brain RT or not. Radiotherapy people always propon towards giving an RT radiotherapy, but this patient was not given radiotherapy and was started on osimertinib itself. So these are the images. We can see brain is studded with lesions, and multiple asymptomatic brain metastatic lesions were seen. And after 5 weeks, we can see that the lower images C, E, F, G, and H. These are actually images showing which was taken after 5 weeks of therapy with osimertinib, and it shown that complete CNS response with no lesions left in the brain. So intracranial outcome of de novo brain metastasis treated with osimertinib alone in patient with newly diagnosed EGFR mutated non-small cell lung carcinoma. It was a cohort study, retrospective cohort study, where patient was selected from an institutional database and they had a diagnosis of EGFR mutated non-small cell lung carcinoma. All of them were treated with osimertinib and between 2014 and 2022 and received osimertinib alone as initial therapy after first brain metastatic diagnosis. And most of them had at least one intact brain metastasis not previously treated with systemic or local therapy at the time of osimertinib initiation. And baseline MRI before and at least one scan after was done. So median age was around 64 years. And as we can see, majority of patients, 69% of patients were non-smokers and 72% of patients were female, which is very well fitting to our profile of EGFR mutated lung cancers. And 94% of patient at the time of diagnosis itself had got brain metastasis. So the observations at baseline pre-osimertinib scan, you can see from the image, there were multiple ring enhancing lesions, which are suggestive of brain metastasis. And the second row, the images show regression of disease is observed 2 months post osimertinib, and the third row shows 34 months post osimertinib, where disease is completely disappeared and completely resolved until 34 months post osimertinib. So the observations from this cohort study was there were 36 patients who had a median interval from brain mets diagnosis to first line osimertinib of 25 days. In total, 136 previously untreated brain metastasis. Overall, 105 lesions had complete response. That was corresponding to 77%. So of the study population, 77% of the patient had got a complete brain response and 31 had got partial response in the subsequent MRI scans. This reflects a best objective response rate of 100% and 2-year overall survival was around 80% for all these patients who were included in the study. CNS progression rate at 1, 2, and 3 years were 21, 32, and 41% respectively. So now recent guideline updates, what does they suggest? So this is an NCCN guideline. It shows that we know that all patients with metastatic non-small cell lung carcinoma, it is prudent to get tested for EGFR mutation. If any of this targetable mutation is available, then the first line therapy is osimertinib, which is considered to be the first and the best choice. And it has been added to the first line treatment in all the major guidelines throughout the world. Thank you. I'll be happy to take any questions.
Thank you so much, Dr. Nitin, for the very interesting talk. And I'm sure that we learned that osimertinib is a very effective drug indeed in the patient of EGFR mutated NSCLC presenting with brain metastasis. So I just wanted to understand from you. So if you have got any experience where you started osimertinib in patient of brain metastasis, EGFR mutated, and without giving radiation therapy, and how did the patient do? If any experience without RT, just managing on osimertinib.
So I had, especially when I was working at AIMS, I had seen multiple patients who had got brain metastatic lesions, and there were few of them who could afford osimertinib, and we started them off with first-line osimertinib, not giving radiotherapy, and they all did well. And I have seen that those patients who have got symptomatic disease and where the response of osimertinib might take a while, we might have to go for radiotherapy, especially when the CNS edema is there, there are features of raised ICT. But otherwise, nowadays in this era, I think we can actually avoid radiotherapy totally in patients with brain metastasis who have got EGFR mutation if they are affording osimertinib.
Absolutely, absolutely. So if there are any other questions? So thank you so much, Dr. Nitin, for this lovely
Thank
talk.
you. Thank
So
you.
next for our webinar, I would like to invite Dr. Anshul Gupta. Dr. Anshul Gupta is consultant medical oncology in Max Specialty Hospital, Vaishali and Max Hospital, Noida. Topic for today is actually, we have all discussed very advanced thing, but the basics are always very important. So topic for Dr. Anshul today is overview of lung cancer. Over to you, sir.
Hi, good evening, everybody. Good evening, Kapil, and next to Ganesh. So I'll be talking about overview of lung cancer. So I hope my slides are visible. So burden of lung cancer in India as per Globocon 2020 data. Well, lung is the most common cancer along with breast, and both in terms of incidence and in terms of mortality. Second uh, most common cause of cancer in males. So as per the AJCC 7th and AJCC 8, there are some changes. So earlier, a tumor which was more than 5 and less than 7 centimeter used to be T2B, now it is T3. And earlier T3 used to be more than 7 centimeter, now it is more than
मेरे पास है उधर ही है.
7
Single
centimeter.
yes.
Doctor, I think you can mute yourselves. So, what are the tools for staging? Bronchoscopy, CT, PET, EBUS, EUS, mediastinoscopy, MRI brain are the various modalities that we use for the baseline staging in lung cancer. There's always been a debate between CCT and PET-CT for staging of stage 3 NSCLC. So lymph nodes which are more than 10 mm along the short axis are a predictor of malignancy. CT alone has a limited role due to a lower sensitivity, 55%, lower specificity of 81%. Addition of PET to CT provides overall sensitivity of 90% and a specificity of up to 95%. So it may help in selecting appropriate procedure by tissue sampling by providing the more sensitive images. So this factor for occult N2, well, depending upon the SUV max, there's a study that if SUV max is more than 4, then the chances of occult N2 meds are 10% or higher. If they're 0 to 4, then they're up to 2%. Of course, as the size goes on, increases, the chances of occult N2 metastasis also increases. So, to remember, central tumors, increased size of tumor and higher SUV and PET, they are the markers for possibility of an occult N2, which is not visible on the PET. So how do we find out the nodal positivity in such situations? So we do mediastinal staging. So less invasive is EUS and EBUS biopsy, and invasive is mediastinoscopy. So mediastinal staging recommended techniques are EBUS and EUS. If clinical suspicion of N2 is high even after a negative EBUS, then mediastinoscopy is recommended. So when is invasive mediastinal staging or mediastinoscopy indicated? If it's a central tumor, if it's a tumor more than 3 centimeters, if there is extensive infiltration of the mediastinum with no evidence of extrathoracic positive N1 disease. And bulky N2 on CT need no invasive confirmation. They're taken as yes. Discrete N2, they are taken as yes, regardless of the PET result. So normal mediastinum on CT, but positive on PET, they're taken as yes. If they're negative on PET, then taken as no. So this is the mediastinal staging algorithm of the protocol. I think we've gone through this. So if it is C, mediastinal lymph nodes are negative on PET or imaging, and if there is low probability of unforeseen N2, then we go directly for the surgery or the definitive procedure. If there is CN1 or CN0 with high probability of occult N2, then we do confirmation by tissue EBUS, by EBUS or EUS. If it's positive, then we go ahead and do the multimodality treatment. If it is negative, then we go ahead with the surgery or the treatment. If mediastinal lymph nodes are positive, if they're non-mass or non-bulky lymph nodes, tissue confirmation is required. If it is positive, taken as that. It's negative, then multidisciplinary evaluation of surgical staging may be done. That is mediastinoscopy, and then it can be proceeded with respect to that. If there are bulky lymph nodes, then of course no tissue confirmation is required and they are considered to be positive. So these are the various techniques which can be used for evaluation of nodal stations. And this is a small table which represents which all techniques can evaluate which all stations. So again, non-invasive and invasive modalities regarding the sensitivity of that. As you can see, the CT scan is least with 55, and then PET increases, EBUS, mediastinoscopy increase high, and VATS has the highest of close to 100% sensitivity. So NSCLC was once considered as a single disease until distinct subtypes, characteristics have been identified. They are relevant for the treatment planning and from the diagnostic point of view. So SCLC again is another entity within NSCLC. There are patients who are oncogene addicted, which have mutation in EGFRL, cross, RAF, etc., etc. The ones they can also be segregated based upon the PDL1 expression and TMB expression. So it is now fairly established that lung cancer management there has been a paradigm shift, and targeted therapy for the oncogene-driven addicted cancer as well as immunotherapy has changed the landscape of the outcomes in lung cancer. So many approvals have taken place: pembrolizumab, atezolizumab, Nivo-IP combination, then for targeted therapy, crizotinib, vellotinib, gefitinib, entrectinib for Entrec, osimertinib for EGFR mutated, and so on and so forth. So these are the various targets which can be seen in lung cancer. NSCLC, RAS, ALK, EGFR, ROS, RET, Entrec, HER2, BRCA, PIK3, AKT, MET exon 14 mutation, and others. So there are 7 molecular alterations with FDA-approved therapies, which are MET exon 14, RET, Entrec, BRCA, ALK, EGFR, ROS. So as the time goes, we are developing more and more therapies for the others. Current guidelines on neoadjuvant and adjuvant chemotherapy depend on the type of the disease, stage, and the findings of the surgery. So stage 1, obviously observation is recommended. Stage 1B or 2A. So MDT needs to be done for the need for chemotherapy. Stage 2B onwards, definitely chemotherapy is required. So the findings of the surgery and surgical resection margins affect adjuvant treatment decisions, more so for the radiation. So there's a incomplete resection R1 and R2, then resection is preferred. If stage 2B is there and incomplete resection is there, then the resection plus chemotherapy or chemoradiation. And if it's a stage 3A or 3B, then of course a concurrent chemoradiation, either or sometimes sequential, may be required. If it's a complete resection, then stage 1 and 2A, again in 1B and 2A high risk can be given. Stage 3 and 2B, of course, require chemotherapy. So after the initial treatment, more than half the patients with residual NSCLC, they recur within 5 years, and 40 to 50% remain cancer-free, but 60% they do develop either a local or most likely a distant metastasis. Latest ESMO guidelines recommend that adjuvant therapy can be considered in patients with stage 1B with the primary size more than 4 centimeter due to clear evidence of benefit. So I think we all know that Lesch meta-analysis is the first meta-analysis which proved the benefit of adjuvant platinum-based chemotherapy. Hazard shows 0.9 and absolute benefit of 3.9 and 5.4% 3 and 5 years respectively. So when we talk about whether we should give neoadjuvant or not, how good does it work? So for stage 2B to 3A, neoadjuvant hazard is 0.87, adjuvant hazard is 0.89. I think this forest plot shows us that for most part, preoperative therapy can be used, or neoadjuvant therapy can be used. So target therapy is moving to early stages. ADAURA has improved DFS with osimertinib in resected EGFR mutated NSCLC. Edzonizumab has also shown improvement in DFS as well as OS in adjuvant setting. So just quick word about radiation. So now the therapies have evolved, IMRT, IGRT, and other reason involved evolution in the type of radiation has led to higher resolution or a better delineation of the gross target volume with lesser effect on organs at risk. Again, these are the newer modular techniques, and the 5-year overall survival has now gradually increased, and the dosing which is required has now become lesser. So, chemotherapy with or without radiotherapy is standard of care after complete resection in stage 3, of course, and this has been proven by a number of trials. So, checkpoint inhibition is also moving to early stages on resectable stage 3 and SCLC as per PACIFIC trial. Durvalumab has been used in consolidation in NSCLC, and it demonstrated an improvement of overall survival compared to historical OS in unresectable NSCLC after CTRT for consolidation. Then there are emerging treatment paradigms, immunotherapy and targeted therapies. FLORA has been discussed, and Alex, for alectinib for ALK mutated cancers, they've practically more than doubled or even increased the PFS and OS even further. The emerging therapies are for Metexon 14, crizotinib, and selpercatinib, and then red rearranged for cabozantinib, bendatinib, Entrec, larotrectinib, entrectinib, and of course, HER2 mutations, trastuzumab deruxtecan. So the survival has now increased with, patients reaching 5 years, 7 years survival. I think that has, kind of changed the definition of how we look at metastatic lung cancer. Immune therapy has been one of the modalities which we go to when we do not find any oncogene-driven pathways. CTLA blockade and the PD-1, PD-L1 blockade are the two pathways which can be used. So over a period of time, so many immunotherapies have been approved. And as we see, the survival has also increased based upon the addition of immunotherapy. And so checkpoint inhibitors have improved survival. As you can see with this, the curves are beautifully separating and the survival has increased. Keno 0 to 4 showed the improved survival of pembro with the chemotherapy. The checkpoint inhibition is moving to early stages. So multiple trials, Keynote, NVIL, IMpower 101 are ongoing, which have, and some of them have actually been completed as well, which have shown benefit of addition of immunotherapy in neoadjuvant or in adjuvant setting, perioperative setting. ADCs are a new thing in all of oncology. CAR T-cell therapy is quickly coming up for even solid organ cancers. So I think a key takeaway from this talk is that the management landscape is fast changing in NSCLC. Few therapies have a huge potential to improve survival, especially when detected in early stages. So OS is improved across various subtypes. The ease of pills over infusions in target therapy has improved the quality of life. And of course, pulmonologists, not just pulmonologists, I think everybody, it's a multidisciplinary team which leads to the improved quality of life and improved overall survival outcomes. So with that, I thank everybody and back to organizers.
Thank you so much, sir, for the enlightening talk. So while we are discussing about the mutation, it is always important to go back to the basic and learn about how the staging and basic workup is done for lung cancer patient. So thank you so much. Next for the talk, I would like to invite Dr. Aman Chaudhary. Dr. Aman Chaudhary is consultant medical oncology in Bharati Vidyapeeth, Pune. Topic for him is going to be molecular biomarker testing in lung cancer. Over to you, Dr. Aman.
Hi, thank you, Dr. Kapil, for having me today. And can I request the organizers to please move the slides for me? So I'll be talking today on molecular biology, molecular biomarker testing in lung cancer. Next slide. So I'll be discussing under following heads. We'll be discussing lung cancer in India, biomarker testing in NSCLC, evolution of biomarker testing in NSCLC past in the current scenarios, and the key takeaways. Next slide. So the burden of lung cancer in India, as per Globokine 2020, we can see that the breast was the most common malignancy, followed by lip oral cavity, followed by cervix uteri, and followed by lung, then colorectal. If you talk about only males, then lip oral cavity, followed by lung, stomach, colorectum, and esophagus. So lung was the second most common if we consider only males, and if we consider all both the sexes, then lung was the fourth most common. Next slide. Next. So if we look at the mortality, so breast is the, if you look at the breast is the most common killer. If we talk about all the cancers, and the cervix uteri being the second most common, lip oral cavity being the third, and lung cancer being the fourth most common cause of death related to cancers. Next slide, please. 50% of patients with advanced non-squamous NSCLC have a driver mutation targetable with an FDA-approved agent. For ALK, we have crizotinib, alectinib, ceritinib, lorlatinib, brigatinib. For EGFR, we have gefitinib, erlotinib, afatinib, osimertinib, dacometinib. And for KRAS, we have sotorasib and adagrasib. And for MET exon 14 skipping, we have capmatinib, tepotinib. For HER2, we have trastuzumab deruxtecan. For ROS1, we have crizotinib and entrectinib. For BRAF, we have dabrafenib. For RET, we have sulpercartinib and pralsetinib. For NTRK, we have entrectinib and larotrectinib. Next slide, please. So the importance of biomarker testing in small cell lung cancer cannot be overemphasized. It can be seen from the Kaplan-Meier curve that with the use of target therapy, median OS can be achieved close to 18.6 months, and with no target therapy, it's close to 11.4 months only, and the difference was statistically significant. So studies have shown that patients with identified actionable mutations who receive appropriate target therapy have improved outcomes. Next. So the guidelines, various guidelines recommend biomarker testing in non-small cell lung cancer. ASCO guidelines recommend EGFR, ALK, ROS1, BRAF, MET exon 14 skipping, RET, NTRK, and PDL1. NCCN also recommends all this testing, but in addition to that, also recommends KRAS mutation. Next. So discussing about the methods of tissue testing, DNA sequencing by either NGS or PCR can be used. It detects insertions, point mutations, deletions. It can also detect aberrations in EGFR, KRAS, BRAF, HER2, MET. RNA sequencing is used to detect usually the fusion abnormalities, and so it's more sensitive for ALK, ROS1, RET, and NTRK. FISH can detect ALK, ROS1, and can be highly specialized, can be faster, and IHC can detect ALK, ROS1. And it's an easy test, fast, but not reliable or sensitive enough to get treatment. It can also detect PDL1 expression. Next. So evolution of biomarker testing in NSCLC. Next slide. So the tissue journey biopsy analysis for preliminary diagnosis, we can either get a tissue with a resection, excision, or small tissue biopsy, from which we can prepare FFP block. Fine needle aspiration or exfoliator cytology can also give us the sample, and the fluid can be used either urine, ascitic fluid, pleural fluid, sputum, CSF, or and through that we can prepare FFP block, or we can prepare non-cell slide block, and liquid biopsies can be done using cyst fluid or blood. And the key person involved in this are surgeons, pathologists, allied health professionals, medical informatics. And for after the preparation of blocks, we can either go for histology assessment, or we can look at the cytology. Parallelly, we can also run IHCs to look for PDL1 expression, FISH for various biomarker testing. After DNA extraction, we can subject it to PCR or MSI or whole exome sequencing, whole genome sequencing, and all. And next slide, please. So biopsies can establish diagnosis, determine histologic subtype, and can also detect biomarker mutation if there is any. Histological subtyping, squamous or non-squamous for biomarker testing, primary tumor or metastatic lesions are equally suitable. Bone biopsy can be suboptimal due to decalcification, degeneration of DNA. Liquid biopsy are another option. Test for EGFR, ALK, ROS1, BRAF, V600E, and TRK red, MET, exon 14 in all non-squamous and SCLC is to be done. For broad NGS testing to detect most mutations using least amount of tissue. For squamous and SLC, consider testing in young, never light smoker, or a Baptist specimenist of mixed histology. Test for PDL expression is to be done in all NSCLC. Completion of testing within 10 to 14 working days is recommended. Next. Circulating DNA testing has the potential to be applied across all stages of NSCLC and throughout the treatment pathway. It helps in diagnosis and treatment selection. It also helps in monitoring prognosis, response to treatment, and progression or relapse of disease. ctDNA testing overcomes some major challenges associated with tissue testing. It's minimally invasive for patients, allowing for serial biopsy if needed. ctDNA in the bloodstream is comprised of DNA from all tumor sources in the body and captures both tumor heterogeneity and tumor changes over time. Circulating tumor DNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung cancer. Next, please. So, circulating tumor DNA may be used to detect MRD after surgery in resectable NSCLC. And there was a TRACER-X study, 24 early stage NSCLC patients followed longitudinally after section. And ctDNA profiling was done. 93% of the patients with disease recurrence were MRD positivity, and 90% of the patients without recurrence were MRD negative. So, in TRACER-X study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before the disease was picked up by standard imaging. So, additional studies to assess ctDNA for monitoring treatment response and relapse in early stage NSCLC are ongoing. Next slide, please. So, comparison of tissue versus liquid biopsy, there are similarities and differences between tumor tissue and liquid biopsy testing for molecular alteration. In tissue, sample acquisition is by invasive surgical techniques. Liquid biopsy can be done with a simple blood draw, generally 10 ml of whole blood. And if we require repeat sampling, it will be difficult for a tumor tissue to be sampled repeatedly. But for liquid biopsy being minimally invasive, we can go for a serial testing if we want. And correlation with histology and cellular phenotype is possible with tumor tissue. One direct correlation between ctDNA results with histology or cell type is not possible, which is a major drawback. And sensitivity of the assay, if we talk about lower tumor cells content acceptable with sensitive techniques, and very sensitive, its liquid biopsy is very sensitive method required as ctDNA may comprise less than 0.1%. And if we talk about the evidence of clinical utility, substantial evidence of initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced SCLC. Less but increasing evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced SCLC. Next slide, please. So multiple genes are involved in SLC. Single gene reflex testing or multiple gene testing can be done as shown in the following figure. Single gene testing can be done with in any order we can do for EGFR, ALK, other genes, and if we find any mutation, then we can use any targetable mutation. Targetable TKIs. And with next generation sequencing, you can do multiple genes testing at one time only, and if we find any actionable mutation, we can target that mutation with the specific drug. Next slide, please. So what are the advantages of NGS? Next, NGS has a number of advantages over single gene tests as the number of clinically actionable biomarkers has increased. The ability to evaluate all known molecular alteration in a single test has given NGS a major advantage. If one or few molecular markers are needed, higher cost and long turnaround time versus single gene. If many molecular markers are needed, reduced cost, shorter turnaround time, and lower tissue requirement versus single gene. So pros include detects a broad range of molecular alteration in single sample, may identify new markers that could offer additional treatment options for a patient and or provide information to help the development of new and more effective treatment. Cons include its high complexity of workflow that requires experienced personnel. Advancements in the field of NGS are evolving rapidly, and patient and clinical community must receive sufficient education in this area. Next, please. So techniques and molecular landscapes, we can, you detect mutations including single gene assays, Sanger sequencing, para sequencing, PCRs, MLPAs, and next generation sequencing is fish, and so on. Next. So again, EGFR, can be detected with PCR or NGS or IHC, RAS with PCR, MET with, fish or PCR or NGS, ALK by IHC, fish or PCR, and so on. Next, please. So EGFR mutation in lung cancer. Next. FFP section, fresh frozen or alcohol fixed specimen can be used for PCR based assays. Cytology samples are also suitable. Cell blocks are preferred over smears. And discordance between EGFR mutation status in primary tumor and corresponding metastatic sites are rare, so anyone can be used. Next. So, word about EGFR mutation test in early lung cancer. Next. So NCCN recommends, consider adding molecular testing for EGFR mutation to be performed on diagnostic biopsy or post-surgical resection sample to ensure the EGFR mutation results are available for adjuvant treatment decisions for patient with stage 1B to 3A non-small cell lung cancer. For patient with EGFR mutation positive NSCLC who receive previous adjuvant chemotherapy or are ineligible to receive platinum-based chemotherapy. Next. So advantage of PCR over NGS over PCR is that one study showed that 48.6% of EGFR exon 20 insertion mutation identified by NGS are missed by PCR. Out of the 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified by PCR. So targeted PCR approaches are needed. Few word about ALK rearrangements. Next. So in most cases, ALK-IC is 93 to 100% sensitive and specific compared to fish. False positivity rate of 0.1% is there with fish. IHC is less expensive, hence more widely adopted. Next. ROS1. Next. So we follow this algorithm for predicting genetic testing in advanced non-small cell lung cancer for finding ROS mutation. Any patient adenocarcinoma or non-squamous and non-smoker with squamous histology, if EGFR, and KRAS, done. If they are negative, we test for ROS1. ROS1 IHC is to be done first. If ROS1 is positive on IHC, we do reconfirm with the use of fish. If ROS1 fish is done, then it's positive, then we consider, retesting with the IHC method if we are not very sure. So detection of elevated ROS1 protein levels by IHC may provide cost-effective screening prior to confirmatory fish testing. Next. So KRAS mutation are mutually exclusive with EGFR and ALK and account for 30% of lung adenocarcinoma. The most common of these arise in codon 12 and 13 with the G12C variant found in 13% of patients. Can be detected by PCR or multiple gene NGS panel. We have sotorasib and adagrasib for treatment of KRAS mutant lung cancer. Next, please. So BRAF mutation, BRAF mutation BRAF V600 mutation, forms more than 50% of BRAF mutation cases and is thought to be more prevalent in non-smokers and non-V600 mutations such as V600K, G4663 and G469A are less prevalent and occur in 17% of patients. 1 to 5% of patients with NSCLC can harbor BRAF mutation. It can be detected by PCR or NGS panel. We do have, dabrafenib plus tremelimumab for V600E mutations. Next, please. So MET tyrosine kinase and MET exon 14 skipping mutation, can be seen in 3 to 4% of non-squamous NSCLC and 30 to 20% of sarcomatoid cancers. Majority of MET exon 14 skipping mutations can be detected by DNA NGS, but increased sensitivity is there if we use RNA NGS. Next, please. So IHC is not recommended for exon 14, MET exon 14 skipping mutation. FISH is not recommended. PCR either DNA or RNA can be done. RNA is better. NGS, sorry, NGS RNA is more better, but DNA can also be used. Next. So RET, it forms 1 to 2% of non-squamous NSCLC and 20 to 30% of Papillary thyroid carcinoma, majority of red fusions can be detected by DNA NGS, but increased sensitivity with RNA NGS. Next. So red fusion can be detected by IHC, FISH, or DNA NGS, RNA NGS. The pros of IHC includes its potential for local implementation, and RNA NGS on the other hand obtain fusion pattern information without intron coverage issues and directly assess fusion expression. Con include highly dependent upon RNA quality. Poor quality leads to a reduced sensitivity. Should we consider using it? Yes. Majority of red fusions can be detected with DNA NGS, but sensitivity can be increased by RNA NGS. Next, please. So to test for NTRK fusions, RNA NGS is most sensitive. ISC is widely available and has a fast turnaround time. Choice of assay will depend on institution, resource, and clinical context. Reflexive to NGS versus IHC reasonable for NSCLC due to low prevalence. Next, please. So, excuse me. NTRK can be detected by IHC of FISH. IHC is rapid, detects transcribed and translated events, low cost, single test. But FISH is rapid. Disadvantage of IHC include depletion of tissue can occur. Fusion partner is not known. With FISH, we can, sometimes get fusion partner as well if we use the dual probe assays. The choice of assay will depend on again institution, resource, and clinical context. Reflexing to NGS versus IHC is reasonable for NSCLC due to low prevalence of NTRK fusion. Next, please. HER2 mutation is rare, constitutes 2 to 5% of NSCLC adenocarcinoma, mostly exon 20 in frame insertions, mutually exclusive with other mutations, mostly seen in never smokers, worse than other subtypes. And HER2 mutation and application must be identified using an NGS DNA panel. IHC used to assess HER2 overexpression seen in 15% of cases. Next, please. So this is the 2022 treatment paradigm for molecular positive biomarker. If we have EGFR positive, classical deletion 19 or L858R, we may use osimertinib, erlotinib, gefitinib, afatinib, or dacometinib. And on progression, we can use further lines of chemotherapy. If exon 20 insertion, we can use amivantamab. And for uncommon mutations we may use afatinib or osimertinib. For ALK, we can go for alectinib, brigatinib, lorlatinib, certinib, crizotinib. For ROS1, crizotinib, and entrectinib. For BRAF, p we may use dabrafenib, pertamatinib, and TRK, and entrectinib, larotrectinib. Let we have sulfacartinib or prasartinib, metaxon 14, we can use capmatinib or tepotinib. KRAS G12C, sotorasib. Next, please. PD-L1 overexpression in SCLC. Next, please. So PD-L1 antibody can be tested using various platforms, including Daco Ventana. For pembrolizumab, the companion is Daco 22C3, and we take positivity as more than 1% or more than 50% for single agent pembro. Next, please. So this slide shows the various testing modalities for PD-L1 testing on various platforms. Next, please. So biomarker for immunotherapy in SLC, it's a controversial topic. PD-L1 sole current biomarker able to guide immunotherapy. Imperfect PD-L1 negative tumors can still respond, albeit mostly when added to chemotherapy. Tumor mutation burden form a marker for response not currently used, conflicting correlation with survival and checkmate studies. MSI high, MMR not used or relevant in lung cancer. LAG3 possibility related to resistance to immunotherapy being studied. Next, please. So to conclude, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Samples should contain adequate tumor content, at least 10% to prevent delay in processing. Ideal TAT is 2 weeks, that is 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated TAT. Next. Oncogenic targets and testing methodologies. Again, we have discussed it, in various slides. EGFR, PCR, NGS, BRAF, PCR, NGS, IHC, KRAS, PCR, NGS, ALK, FIS, NGS, or IHC, ROS1, the same. For redfish or NGS, for MET exon skipping NGS. So clinical guidelines strongly recommend broad molecular profiling to identify rare driver mutation for which effective drug may be available, or to appropriately counsel patients about available clinical trials, broad molecular profiling is a key component of the improvement of care with NSCLC. Next, please. Thanks a lot for patient hearing. We'll be happy to answer if there are any questions.
Okay, sir. If there are no question, can we close the?
Thank you so much, Dr. Aman.
Okay, thanks a
And
lot.
with this, I think we come to the end of our session. And thank you everyone for joining. So this was a very insightful discussion, and we had a very lovely evening. I think all of us got to learn a lot by this. Thank you all the attendees. Thank you all the speakers. Good night. Thank you, everyone.
Can we close this session?